Welcome to episode 2 of Focused Antenatal Care that we are still discussing about this booklet. In episode 1, we talked about further support, and if you have not watched episode 1, kindly click the link that appear up here on Focused Antenatal Care episode 1 on further support. Today we are continuing with discussion of this booklet, and if you love this channel, please click the red button written subscribe, turn on the notification bell for more videos that we will post. And also you may support us by donating to this channel by the M-Pesa number that appears up here, or even the PayPal number or the PayPal link that is written on the description below. Simply click it and it will redirect you to your PayPal account, and you can donate something to support this channel. Otherwise, let's continue with the discussion of this particular booklet, and today we are starting to discuss about section 1, which is maternal profile, which is very important, and we normally find that some do not provide accurate details on the maternal profile, particularly the age and the number of pregnancies, and even the pregnancies that has been lost, that is miscarriages or abortions. Weight and height will be taken in the hospital, and that one we'll talk about. Last menstrual period, this is a very big problem because most of the prima gravida, that is those women that are pregnant for the first time, they normally forget their last menstrual period, and this last menstrual period is what is going to help us to calculate what we call EDD, that is expected date of delivery. Of course, your marital status you will state, and your educational status, address, and even telephone number, your telephone number, and even the next of kin's telephone number and their relationship, because there are sometimes that we need to consult over something. You are in labor or you have delivered, the baby does not have anything. We might call the next of kin to provide the necessary requirement for your baby. That is very important, and kindly do not forget to even indicate the alternative number, even of your neighbor or somebody close to you, that if we miss the immediate next of kin, we can call that your neighbor, and we get assistance very fast. Of course, during our history taking, we'll take our your medical and surgical history, and you will also tell us whether there is any operations and whether you are diabetic or not. We'll talk about that into details, whether you are hypertensive, whether there is a blood transfusion that you've been transfused before, whether you've suffered from tuberculosis, and if there is any drug allergy, you will also specify. Even family history of twins. Family history of twins is very important in this scenario. And if you have not watched my video about how to conceive twins or factors linked to twin pregnancy, click the link that appears here about how to conceive twin pregnancy. It's very important, and if you follow what I've discussed there, you might end up getting twins. Previous pregnancies are also very important. To get that, maybe due to labor, a mother may not give us details, but it is very important, because initially in our last discussion we talked about child spacing and the importance of child spacing. So previous pregnancies in order, and the year you delivered, the number of antenatal care you attended, place of deliveries, whether it was through TBS or through health facility, and the maturity, how long was that pregnancy, and of course duration of labor and type of delivery, whether it was cesarean section or it was normal vaginal delivery. If you delivered through cesarean section, through this your antenatal clinic, we will be able to continue teaching you that you should be delivering in the health facility, because when you have cesarean section, there is causes of cesarean section, the reason why we do cesarean section, and some you might not be able to deliver through vaginal delivery forever. So there will be no trial of labor, particularly in cases of CPD, cephalopelvic proportion, where the child cannot be able to pass through your pelvis towards the vagina for delivery. You must just deliver in the hospital through cesarean section. So it's very, very important to tell us even the birth weight, sex, and the outcome of pregnancies, the outcome of delivery, because we have mothers who have bad obstetric history. They have reasons, they do not have reasons why they are losing pregnancies, and we will also discuss this, because if a mother is always is developing miscarriage every time, there must be a reason that if you are attending antenatal care, these reasons we are going to discuss, and we might find a problem to your solution. And even puerperium, that is the first 6 weeks, if there is a problem, you should be telling us. It might also be linked to these current deliveries. And going on, we'll do your general examination. We'll see whether you have mood swings, whether you are happy about the pregnancy, whether you are sad, or whether you are scared of the labor, or you are scared of cesarean section. Of course, we will do a lot of counseling to you so that you develop this preparedness and be ready to deliver. And of course, we'll check your blood pressure. We are going to talk about that in terms of antenatal profile. We'll check your height, and we'll also discuss a lot about your height and cardiovascular system, the way your heart is beating. We'll also discuss that. Respiratory system, that's the way you are breathing. We'll discuss about that. Your breast, whether this breast is well and good, that is preparing for breastfeeding. Your abdomen we will examine in terms of the maturity and the growth of the fetus. Of course, we'll do vaginal examination, and in this we normally gain consent, because some women do not want to be examined in terms of vaginal examination. How will we know about dilatation or when you are ready to deliver? It is this vaginal examination, initial vaginal examination, and how the nurse will carry on with subsequent vaginal examination to elucidate and explain to you when you are about to deliver and the dilatation of the cervix. Of course, in vaginal examination, we look at discharge, or whether there are ulcers. They can be tied to a problem that may affect you or even affect your baby. And in discharge, in this scenario also, I've talked about urinary tract infection. If you have not watched my videos about UTI, click the link that appear up here about urinary tract infections and how we can manage them. I will not talk about much in this urinalysis, in this vaginal discharge and genital ulcers. Of course, we will now start by antenatal profile. Because I've mentioned urinalysis, let us start discussing about urinalysis. We'll be able to take your urine sample, and in this urine sample there are several parameters that we will be looking at in relation to this particular pregnancy. Of course, we'll be looking at whether there are sugars present in urine, whether there are proteins, and proteins might be a sign of urinary tract infections that I've discussed in detail in my video, and I've told you about the link that you will check. It can be, if you see proteins in the urine, it can be even kidney disease, and also it can be what we call pre-eclampsia or eclampsia. This is called gestational hypertension or PET. Hypertension, that is hypertension in pregnancy or pregnancy-induced toxemia, that we can gauge only if we do your blood pressure and your urine analysis. Now, when we see proteins, when we elicit proteins in your urine and we correlate with the signs and symptoms you are presenting with, mostly hypertension in pregnancy sometimes might not present with typical symptoms, but a patient may have lower limb swelling together with high blood pressure. So in this, we have a diagnosis of what we call pregnancy-induced toxemia and this is hypertension in pregnancy, and we will be able to manage this. And remember, this pregnancy-induced hypertension is very, very dangerous, and it kills most of women, particularly the prima gravida, those first-timer, the number one pregnancies. So you be careful if you see your lower limb swelling, and maybe you start developing epigastric pain, that is pain around this area, and you develop blood vision and headache. We will not even think of malaria if a woman is presenting with those symptoms. Of course, malaria will be our number 2, and we'll be able to screen you of malaria. We'll do blood slide for malarial parasites, and if we find that there is malaria, of course, we will start treatment straight away. Another important antenatal profile is your hemoglobin level, the level of your blood. And this is very, very important because almost all women, when they deliver, they develop some tears, and there is also some blood that are gushed out during delivery through the placenta. And this one, a woman can even develop what we call postpartum hemorrhage, that is maybe immediately after delivery. And if you know your blood levels, we will be prepared, because we'll be prepared to prevent you becoming severely anemic. We can even transfuse you before delivery or immediately before delivery to prevent you from complications. So it is very, very important for each and every pregnant mother to attend antenatal care for the sake of all what we are talking about right now. And in that hemoglobin level, we also do your blood grouping, and this is very, very important, and I want you to listen very, very carefully in this particular context. Of course, you will determine which type of blood group you are, whether you are rhesus negative or rhesus positive. And this rhesus scenario, or these rhesus factors, are very, very important because we are more concerned with mothers who are rhesus negative. Rhesus negative. If you marry a man who is rhesus positive and you are rhesus negative, there are high chances that your newborn will be rhesus positive. And if you are a mother who is rhesus negative, there is a problem of this, your subsequent pregnancies not faring well, and it can lead to even death in utero or immediately after birth due to what we call rhesus incompatibility, or what we call rhesus isoimmunization. So every mother should be able to know her rhesus factor, and this is a very number one component in looking at focused antenatal care, so that if you are rhesus negative, then we will be able to inject you with a drug called Ante that we normally give at 28 weeks and 34 weeks, and also immediately after delivery. It is preferred that it should be given around 72 hours after delivery. Also, this drug can also be given when you had miscarriage or during amniocentesis. These rhesus factors is very, very important, and I need you people to be keen on it. Also, we'll do what we call VDRL, that is venereal diseases for research laboratory. We are looking at a disease called syphilis. You know, syphilis causes problem both to the mother and the unborn child, and even causing complication after delivery. This is a child delivered with a mother who had untreated syphilis, developing what we call multiple organ failure. Now the child will develop multiple organ failure and will not even celebrate the first month of life because of this. Intrauterine, it can even result into growth retardation and even miscarriages. And also in this miscarriage, can miscarry or even deliver, but deliver what we call stillbirth. Deliver stillbirth meaning child is already dead because the mother was not screened for syphilis and it affected the child. Now, it is very, very important for you to come to the clinic to have this screening done. And I will also encourage men, because sometimes you screen a mother is positive of syphilis, but the man is still outside there. You start treatment, she goes back to the husband, get reinfection, then the problem continues. This is why in my first video I talked about fathers should be able to accompany their wives during antenatal care even once, so that we do this particular screening in terms of screening about syphilis or even HIV that now I'm going to talk about. Screening of HIV is very, very important, and you know very well HIV is a burden to Kenya, and we will be able to talk to you in terms of counseling and providing you with psychological preparedness of the outcome, whether it will be positive or whether it will be negative. In this booklet, we have reactive, which means that you've tested positive of HIV, or non-reactive, you've tested negative of HIV, or even not tested, because there are some clients that you talk to them very well, you take them through the counseling, but they still refuse to be tested. Some normally give a mere reason that I cannot be tested of HIV when my husband is not there. That is very understandable, but now this is your life. Now I'm encouraging also men, please accompany your wives so that we can be able to do this test together. In relation to HIV, if we get that you are HIV positive, the mother is HIV positive or the father is HIV positive, we'll take you through post-test counseling, and even nowadays is test and treat. We don't delay HIV. We do preparedness, ART preparedness. We counsel you very, very well, and we initiate antiretroviral to the father and to the mother. Of course, we also take care of your unborn child. There are drugs that will be given when you deliver that you should start as soon as possible, and we also want to just brush about those drugs, and I will encourage all mothers to be reading this book because it is very, very important. They will be able to know what is taking place even before they come back for the second antenatal care. Now, when a child is HIV exposed, of course, there are several tests that we will do, and we find out that the infant exposed of HIV, we will collect samples, that is called dry blood spot, for DNA PCR at around 6 weeks, or first contacts after 6 weeks. So this one will be able to help us as clinicians. We know how we'll track this your dry blood spot for your infant, and eventually when we will now giving you the result that now your child has no HIV. In some scenario, the mother can be on drugs but the child still turned positive. Of course, now we will start full course of antiretroviral. Now this child, when she's born, we'll give nevirapine syrup at birth, and we give this also at first contact. Given for 12 weeks if the mother is on ART, or till 2 weeks after cessation of breastfeeding if the mother declines or interrupt ART. And we will stop nevirapine syrup if infant turns HIV positive, as I've said, and start full course of ARVs. Of course, we'll dispense also Septrin, which we start at 6 weeks after birth or first contact after 6 weeks, or we will adjust the dose as possible. Now, in this scenario of HIV, it needs preparedness, as I've said, and we will discuss more if this test turn positive if you come to the facility. And also, we will be able to screen you for tuberculosis. We'll ask you whether you have history of cough, history of night sweats, and if we find out that you are depicting signs and symptoms of tuberculosis, of course, the mother will be able to produce sputum, and we will take this for testing, a test called Gene Expert. If you find that tuberculosis is positive, and of course, we will initiate this mother on anti-TBs. Going on, we will also be able to counsel you about everything that now we want to do in terms of antenatal profile. So, in summary, in antenatal profile, we'll be checking your hemoglobin level, we'll be doing your blood group, we'll be checking your rhesus factors, we'll be screening you for tuberculosis, we'll be screening you for venereal diseases for research laboratory, that is for syphilis. Also, if tuberculosis is negative, we will initiate you on isoniazid, that is a drug that used to prevent tuberculosis where applicable, particularly those who are on care on HIV, because HIV predisposes factors contributing to developing of other concurrent diseases like tuberculosis. Now, of course, we'll be able to mark or indicate all those details in your antenatal booklet, so that even if your second antenatal care you are doing somewhere else, not in the particular facility that you've started, they will be able to know what is going on in terms of subsequent antenatal care. And in that also, we'll also counsel you about infant feeding, and in this infant feeding we will indicate whether we've done it or not, and we'll discuss about exclusive breastfeeding in other topics that will come. Thank you so much for listening to this, and we will also continue with subsequent seasons of focused antenatal care. See you in the next video, and if you have not subscribed to this channel, hit the notification bell written subscribe, turn it on for more videos that I will post. Muchas